All right, good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Dr. Kristine Aadland is our speaker tonight, and she'll be covering the process from extractions to implant placement, as well as the digital surgical workflow featuring ACTEON 3D imaging and software. At any point during the webinar, we certainly encourage your participation. If you have any questions, please feel free to type them into the Q&A section of your control panel, and we'll answer them at the end. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And lastly, tonight's webinar is sponsored by ACTEON. So with that, I will throw it to Dr. Aadland.
Well, thank you so much. And thank you for having me, Henry Schein and ACTEON. I'm so excited to be here and sharing probably my unusual journey with surgery. So surgery with confidence. So just a little bit about me before we get going. I graduated from Oregon Health Science University in 2006. I had the opportunity to work as an associate for 3 years, and it's so nice now looking back to say it was such an incredible opportunity. The dentist I got to work with, he had just opened a second practice and needed an associate, and he now you would say is probably a little bit or was a little bit of a cowboy. He loved technology. He loved CEREC, which is one of my huge passions. And he placed implants, which a lot of GPs didn't place implants in or do a lot of their own surgery. But we were kind of in a little bit of a rural community out there. And he was just such a good guide to where I wanted to go. So in 2009, I did a startup practice. And in 2009, it wasn't unlike today where we kind of thought the world was crashing down. So that was the first time we had dentists walking away from practices and going bankrupt. And it was kind of a scary time. I live in Vancouver, Washington, which is right outside of Portland, Oregon. So I'm in a town of about 175,000 people. And in my area where I was opening my practice, I had 90 dentists to compete with in my 5-mile radius. And so when I decided to do a startup, everyone told me I was crazy and I needed to do something to differentiate myself. So I wanted to do it all. I wanted to differentiate myself with technology. And so I started with CEREC and did a lot of same-day dentistry. And then, of course, I really wanted to be this super cool badass in surgery and do endo. And I used technology like Cone Beam to help differentiate myself and get that process going. So it's been a fun journey along the way. It was interesting about 2 to 3 years in, a bunch of my friends had started doing implants and doing surgery, and I was right with them because CE is always more fun to take with people. And I realized I was getting so stressed out when I would see surgery on my schedule. And I would like stomp my foot like a 3-year-old. Like I didn't want to go to school the next day because I didn't want to do surgery. And I kind of pivoted my practice. And so I went into the restorative direction for about 10 years. And people would say, oh, what do you do? What do you like in dentistry? And I'd kind of whisper like, I'm just a restorative doctor. But eventually I just came to own it and loved how I was practicing until COVID hit. And we started seeing break after break and hopeless prognosis and all these teeth that needed to come out. And specialists would only see your patients if it was a 10 out of 10. And we couldn't get anybody in. So one of my best friends called and said, hey, I'm going to go take this course, this implant continuum. Do you want to come with me? And I was really nervous because I'd been down that path and I didn't like it. But then another friend was taking the course and then another friend and 3 of my best friends were taking the course. So out of complete FOMO, I went down this continuum and I never regretted it. I had so much fun. And that's what I'm going to really share and where I'm at today with that. So in that process, I became faculty at a program called the Clinical Pathway, which is part of Implant Pathway. It's a live patient education center. And what's been fun about it is I got into it on the tooth side. So you see live patients in this education, but then they're taken care of comprehensively. And that's where I wanted to be an asset, is to help that well-roundedness. There's a nonprofit. And so if a patient's in a course and they get free or heavily reduced dental care, then we also make sure they have comprehensive care at this nonprofit where there's also an AEGD program. So I help with the CAD/CAM side of the AEGD program and make sure these patients have full care all the way around. And then I hang out in a lot of the surgical courses trying to up my skills. So when I came back from this course and I told my team that I was going to start placing implants, this is one of my 3 associates, one of my fun doctors that I get to work with, mimicking me of what happens when I see too much blood. So it's not really a joke in my office. I have this very pesky vasovagal response called fainting to blood. And this is why I got out of surgery. I couldn't really predict it. And it was just a real thing. Like if I got too anxious about a surgery for whatever reason or saw too much blood, I would literally hit the floor. And it was so embarrassing. And let me tell you, it does not instill confidence with your patients or your team members if you faint during a procedure, after you look in their mouth, especially. So one of my assistants who I've worked with since day one said, if you do this one more time, I'm going to quit, and I can't really work without her. So that's at the time why I gave it up. But getting back into surgery, what's made it so amazing is the technology and the advancements today. So for me, it's guided surgery. It's clear view of what I'm going to do. It's a surgical piezo that helps me tremendously with my extractions, printing. And so I'm really excited to share it. And I will tell you that I am now standing upright at the end of these procedures and loving every second of it. So I'm going to start with cone beam. I started with my cone beam back in 2009 when I did my startup practice, and there weren't a lot of options back then to where they're at today. So it's been fun to kind of look at this journey. So when I was getting ready for this, I just wanted to see, like, where has the evolution been with dental radiology? And this is what it was back in 1896. It really hasn't changed. Like if I look at this picture, I mean, granted, you don't see a lot in those radiographs. They're pretty old though at this point. I don't know how diagnostic they were then, but you look at like that mounting on the wall and you still see that a lot in offices. They've changed a little, but not a lot. Of course, today with digital, it's a lot more clear, so we can get a lot more diagnosis, which is fantastic, but it definitely doesn't tell the whole picture. And that's where I fall in love with the CBCT. So what is a cone beam CT? It is a combination of 3 different technologies. It's your panoramic radiography, your computed topography, and C-arm fluoroscopy. And all of this in combination gives us this screen right here. So this is the ACTEON Prime unit, which I believe is one of their newest units out there. And the image quality is amazing and so clear. So you get these 3 views to look all over the skull. You have your sagittal view, which is your side to side. You have your axial view, which is going to be your front to back. And then you have your coronal view, which is up and down. And why do we like those so much? Well, in a matter of seconds, you get a wealth of information. And these are some of the examples that I'm just going to show. So I have a different unit in one of my practices just because I've had it for so long. And even the evolution in just CBCT in this last amount of time has been fantastic. How often will you be surprised in this? I get this a lot because sometimes, or at least when I started back in 2009, doctors were scared to get a CBCT because you didn't want to be held liable for all of the things. You're surprised about, it says 33% of the time, according to some studies. So that's a third of your patients that you're finding dental problems that you wouldn't have found otherwise. But the good news is, especially as doctors are getting more and more CBCTs in the dental field, you are not held liable for a obscure brain tumor that someone may or may not have. So do you need to go through your CBCTs? Absolutely, with due diligence. And if you find something strange, you should probably pass that off to someone else. But you're not going to be held liable to something that's not within our scope. Third molar extractions. This isn't a procedure that I necessarily do, but I do show this with my patients in the chair. So when I have my comp exams come in with new patients, we do a CBCT, we do 4 radiographs, and then we do intraoral and extraoral pictures. And what's great is when I'm explaining why a wisdom tooth needs to come out to a patient and I can map this nerve, you can do this all chair side. And it is so powerful because the patients can actually see what you're talking about. Because patients get a little nervous when they go and they, even if I'm referring them to an oral surgeon and the oral surgeon is saying, I may paralyze you for life in your face, and they don't really understand why, like I can kind of explain what's going on and what the risks are and take a little bit more time. And so it's just been really helpful. Also for surgeries, obviously, if I'm going to need to know where that nerve is. Orthodontics, if you do orthodontics, you can do ceph tracings in there. And then patient education. This is where I have just really thrived in my practice with the CBCTs, even from the beginning. And a lot of it was just to instill confidence. So here's just a regular PA. And this is a patient that would come in and just say, I'm having pain on the lower right side. And there's an endo tooth and, it looks okay. There's tooth number 29. And is that the mental foramen? Or is there an abscess down there? It looks like there could be decay. The patient can't identify which tooth, you're testing and all of it hurts. But when I take a CBCT of this, it's not only obvious to me, but it's really obvious to the patient. Like you can see the bone blown out on this and the patient goes, oh, okay, yeah, now I see. And unfortunately, this was a hopeless tooth with a crack. And it's easy to tell the patient like, hey, this is, you cracked her tooth from biting down. It's hopeless. Now that tooth needs to come out. It eliminates a lot of questions that we can't always see clearly with just a PA. I had mentioned before, if there's something that looks a little bit odd, there are programs out there that you can send, and it's so easy to upload these at this point, and you get them back typically within a day or 2 days, and these are dental radiologists who read them. They go through and through. The reports are easy to read. Beam Readers is just one of them, and they're anywhere from like $50 to $100. You can charge the patient or not. It just depends on what you want to do in your practice, but there are services out there. The way it works for me is I'm really close with my OMS. So I'll send anything that looks a little strange to my oral surgeon first, and he'll normally look at it and just say, yeah, I might send that in, or no, don't worry about it. Just watch it and have him come back. Or ENTs, like it's good to develop those relationships with them. And those are kind of my first go-tos, but then every once in a while you get something you're like, I need to send that in. So again, a patient comes in, upper left, they're having pain. You can tell there's a root canal with some silver points in it. And, it looks a little suspicious up there, but I hate PAs on the upper posterior teeth, because you have that sinus wall and you can't always see super clearly. But again, CBCT, I can look at those views, and this is an antral pseudocyst. And so even though it's a root canal tooth, there's a lot of pain. Endo isn't just going to be the only fix for this, because that sinus is so full. This is also going to be an ENT referral. And patients really appreciate that you took the time to find this, so that they're not hopping from chair to chair and they don't go spend all this money with endo and then still have pain and wonder what's going on. You're eliminating excuses. And then just some fun things, like this is a full-blown sinus infection. You can tell in the view on the bottom right, both sinuses are incredibly full. Again, just super easy communication with my patients. When sinuses are this full, I'm sending them to an ENT, because this isn't something an antibiotic is going to help fix. Whereas chronic sinusitis, this is where you get that kind of wavy mucus around the sinus wall. This is someone who has constant allergies. They typically know how to help themselves because they've had it for so long. And again, just easy education for the patients. This is one of my favorite ones when you see stuff like this. This is a silolith. So it's a salivary stone. Sometimes patients will pass this on their own. Sometimes you have to refer it to the ENT and they have to really get in there. But these are the cool ones that just like really show up prominently. Patients can get a little scared because of course they're going to automatically think it's something kind of bad. But when you explain it's kind of like a kidney stone that has to go through this little duct, like it's kind of cool. Like these are the fun finds. And you'd be amazed how often you find these. And then you get something like this. So I don't know if anyone wants to guess what this is, but this is some calcifications. And we found this on a scan and it was a man who did not want to go to his physician. His wife happened to be in the chair next door in a hygiene, and she overheard the conversation. And so she made the appointment for him. And the physician said, hey, I think your dentist might have saved your life. Like this is a true carotid artery blockage. And again, we're dentists, yes, but we can catch some amazing things. And I'm proud to say that I took this scan and that this could have saved his life. And then every once in a while you get something like this. This is a little bit more of a mystery because now it's on both sides, and you don't normally get blockages on both sides, and it's a little wavy, a little unusual. And so we were talking to the patient and I was really trying to deep dive to what it is, and she didn't want to admit, but she got Juvederm filler in her cheekbones to set her chin apart and her cheek lines a little bit. And so this is how it showed up, which I didn't realize it was a little radiopaque. It was one of the fillers that they used. So every once in a while you get something kind of cool. This patient, another just an example, patient comes in and has some pain on the right side, and we can't really figure out, the patient doesn't know if it's up, if it's down. We're doing all the tests and it's just, all the tests are very vague. We take a CBCT to try to eliminate things, and sure enough, there is resorption. And it's just so obvious in the scans. Like, that is what I absolutely love about the scans. And now if I look at the PA, I'm like, oh yeah, now I can vaguely see it, but blown up, like it's not something that's going to catch my eye, especially if I was in a hurry with an emergency exam, which you can never be in a hurry for emergency exams because that's when they have pain in every tooth. But again, just obvious. And last but not least, this is a patient who came in, and we started with the picture on the left, and she had just seen an ENT and actually got a biopsy. She was having a little bit of pain in that side, and we thought maybe it was aggressive periodontitis. And he had done a biopsy and it didn't show up with anything major. And then when she came to see me again, she had the picture on the right, and that dramatic change from the white lesions to the angry red. I sent her to the periodontist in my building, and he biopsied it. And unfortunately, it was squamous cell. So I will tell you, I've had 5 totally in my career in the last 15 years of squamous cell. 2 have had successful jaw resections. 3 have not made it. It's terrifying when you find it, and so sad, because that's when we become real doctors. I know we're real doctors, but these are kind of the hard ones. But again, like, you can find things that actually save lives. So huge fan of CBCTs, not just for surgery, but for everyday practice. I don't know how I would practice without it. So if you are thinking about getting a CBCT and don't have one, there are some things that you definitely want to think about and look at. So on the clinical side, you want to look at field of view and the volume. There are many different ones out there. So are you going to use it for ortho? Or are you going to use it for airway? Are you going to use it for surgery only, endo? Some of the endo ones might have a smaller field of view, but they're really, really clear. So make sure you know the primary purpose for what you're going to use it for. Image quality, a lot of that has to do with field of view and the purpose of what you're going to use it for. But I'd say today, there's such a difference with like my machine that I bought over 11 years ago, 12 years ago, than the image quality today. And it's not like it's like our iPhones, like everything just keeps getting better and better. So image quality is pretty fantastic in most of the devices today. Amount of radiation. This, of course, was a really big deal previously when they were first coming out, but now it's pretty minimal, the amount of radiation. I don't have a lot of patients ask anymore how much radiation it is. We always have it on hand depending at what office. I have a couple offices and what machine it is. I typically tell them it's like a flight from here to New York, or a couple bites of tuna fish, depending what they're getting. I always know when there's a Dr. Oz show that happens, because that's typically when they really ask how much radiation they're getting. And then how easy is it to use? We need it easy to use to be efficient, especially for all of our team members. What's your ROI on it? So I love the business of dentistry, and I'm a big nerd. I love Excel spreadsheets. And so ROI is something that's always been really important to me. And when I was first investing in a CBCT, it was expensive. It was like, I think it was $180,000 when I first bought it. And this is 12 years ago, where there wasn't a lot out there. I got to share it with an orthodontist, but still it was such a huge investment. And you can't look at it, or I couldn't look at it as far as reimbursement per image per patient, because I'm a PPO practice, and we see a fair amount of patients, but that's not what I use it for. My ROI is a little bit more intangible, that I have so much treatment acceptance with my patients because they can see exactly what I see. I'm not trying to hide anything. And not only can they see what I see, but if I need to do an implant, I can virtually treatment plan them chair side, so they can actually see what I'm talking about. What is an implant? What is an abutment? What is a crown? And there's so many fun things that you can do even chair side with your patient's involvement. And they just think it's cool. And then they want to invest in you, which is fantastic. And then you need to think about integration. So are your computers up to date? Do they have the graphics card that can support it? And not only on the computer support side, but do you have a team that can support you? So, this is a computer at the end of the day, and it will need updates, and things happen, things break. That's just the world that we live in. And so do you have that support system? And that's really important. If you buy something, from a knockoff company, like, are you going to have that support to help fix it? And then what are your future expectations? Is it a company that's going to invest in the future and help promote? And then space. So this is one of the really big reasons that I fell in love with the ACTEON Prime specifically. So I was introduced to it down at Implant Pathway because that's all they have. And I was really impressed with all the software advancements and the images that it could do and all the treatment planning. And we're going to go over that in a little bit. But more importantly, I bought a second practice back in, I think, 2018. And it is this darling older house that's been renovated in a downtown setting, but we have no space. And as I mentioned before, I can't practice without a CBCT, and I definitely don't expect my doctors to practice without one either, especially during surgery. And we were sending patients over to our office, but I really wanted a CBCT in there. And ACTEON Prime has one of the smallest, if not the smallest footprint. It's amazing. So it fit right in the practice in a pretty small-ish spot. The patients don't feel claustrophobic, and with the view and the quality and the price, like I couldn't beat this CBCT. I'm so excited, and we are just loving it, every image that we get. So all things to really think about and consider. And now let's talk about the fun part. Let's talk about surgery. So in my offices, we do surgery in 3 appointments. And our first appointment is going to be our CBCT and our digital scan. So CBCT, we just need a DICOM file. So in our case, we're using the ACTEON Prime, and then we use a CEREC for our digital scans. And we have some other scanners as well, as long as you need that STL file. So most of our patients do get a CBCT. So sometimes if they're new, we have those on file. But if they had an extraction and graft, and now we're planning an implant later, then we'll take a new updated CBCT. And same thing with the scan. And the great thing about this is all assistant time. This is not doctor time. So assistant time, depending on how long it takes to scan, this is normally a 20 to 30 minute appointment. One of the really amazing features about the ACTEON Prime is that you can design your guides within the software. So if you're doing a lot of implants, this is fantastic because you don't need a third party to do it. And then they make it pretty intuitive, which is what I love. So there's this guide design button on the lower left. And so you have your image, and then you just go through this checklist. So you can see on the left, it says data import, and we're going to import our STL file, which is what we did with either the CEREC or our Heron 3-disc. And we're just going to import that STL file. And so once I import it, I need to tell the computer how to match it up to that upper jaw. And again, we just go down the checklist. This is all super intuitive in the software. And so I'm just matching up the teeth. So 2 is hooked to 2. I just literally tap on the tooth on the STL file, and then I tap on the skull to match them up. And then it overlays it. And then I get to check in the bottom screens, does that overlay look good? And in this, it looks great. It matched up well. And then I plan my implants. So in this case, we're doing 2 implants, one on number 4, one on number 13. Now, here's the difference is I feel comfortable at this point planning my implants, planning my heights. But if you don't feel comfortable or you're at the beginning of your journey, this might be where you want a third-party involvement. Or if you have a great mentor, this is a great opportunity to hop on a call with them, hop on a Zoom, and you can plan it together and say, you know, what do you think? Am I deep enough here? Am I too palatal? Am I too facial? And that's where you're going to get so much help in your placement. And then you make your guide. And then you get this recipe, and this recipe is going to tell you the drill length. So in this case, we're going to do a 3.8 by 10.5. This is a BioHorizon implant. We're doing 21 millimeter guided drills, and then it's an SP2 stop position. And so you have these recipes up. And so this is for tooth 13. The other one was for tooth number 4. And then it's time to print my guide. So I love Sprint Ray Pro 95. It is so easy. It's literally just a clicked print. If you are printing your guides, whether you're doing it from like Sprint Ray Design Services or from Blue Sky Bio, third party, or you're doing them yourself through ACTEON, then my biggest recommendation is you have to get these little sleeves from whatever implant company you're using. make sure you put the sleeve in before you cure your surgical guide. So you print your surgical guide, you take off the supports, you run it through the Pro Wash Dry, and then you cure it. And if you put the sleeve in first and cure it, it will lock that sleeve in so you don't have to use glue. But the greatest thing is if you're doing a lot of implants and you're printing in office, you can do this for less than $4 a guide, which is awesome. So we don't charge for guides in our office. It's something for me so that I don't pass it on the floor. I love guided surgery and I would rather spend that $4. Or even from Sprint Ray Designs, $100. I'd rather just have that for me and my peace of mind, and I don't pass that on. But if you want to pass that on to the patient, then that's fine too. It's however you feel comfortable with your practice. So that's my first appointment, getting ready for my second appointment. So first appointment, we're taking our images, both in our scanning device and our CBCT. And then our second appointment is surgery day. And what made me gain so much confidence is by making this a non-event. So what does that mean? It means that I have this checklist, which I am so happy to share. If anybody wants it, you can change it, adapt it however you want to, but I needed this checklist both for myself, for peace of mind, and for my team members, because here I was introducing a new system and a new service, and they wanted to be just as confident as I was here in the operatory. And that's where that checklist was just so nice and just made everything very smooth. So you can see in my picture on the left, I have my recipes up for my guided surgery. I have everything just set up, ready to go. It's an easy kit. It's very simple, very clean. And it doesn't look scary to the patient either, because like they see the recipe and they see the checklist and then they see how clean everything looks. Again, can't have anything too scary or blood, because otherwise I'm going to hit the floor and pass out, right? And now it's time for surgery. So first thing on my checklist is the guide try-in. The guides, I've really enjoyed printing my guides. They tend to snap in really well. I have these windows that you can put in the software to verify that they're seated all the way. And then it is time for a mini flap. So when I started down this path, I used a tissue punch for everything I did. I would only do abundant bone sites, and I would only do lots of keratinized tissue because I was terrified of laying a flap, because again, I didn't want a lot of blood. But as I started branching out a little bit more and working with my mentors, I decided I actually really liked doing this mini flap. And so a mini flap to me just means we're flapping from the distal line angle to the anterior tooth, and then the mesial line angle to the posterior tooth. You want a full thickness flap. And in order for that to be easy, I just make sure that after I give my local anesthesia, then I will actually just do a little bit of local in the tissue where I'm going to flap. And that tissue, you'll get a really good, nice blanch. And then that tissue will just kind of easily lay away from the bone. And again, not a lot of blood, which makes it easy. And so then it's my flap reflection. I don't need to do a ton on the palate. But on the buckle, I want to do enough, and I make sure that when I'm designing my guide, it actually is going to hold back my tissue. So I want to make sure that it's holding back my tissue, but I also want to make sure that I can get irrigation in and out of there. So it's a little bit of a fine line. And as I've designed more guides, you kind of learn every time. You learn if they're too short, you learn if they're too long, then you just have to grind them down. So if you do that a couple times, then you figure out your sweet spot, and it gets easier every time. All about the reps. And now it's time for drills. So in this case, I'm trying my key in. I put in my drill, my first drill, my 2.0. And what I love about guided is the guide's covering all the teeth. When I'm very confident that I place my implant according to plan on my guide and everything fits, then my drills are going to go right to the right spot. So I have my initial drill 2.0. And then I'm literally just hubbing all the way down. The stops are built into the drills. And then my second drill, my 2.5, pushing all the way down. I have irrigation going through the whole time. And then it's time for my implant. I'm placing my implant through the guide. And then I'm torquing out, in this case, out of 40 Newton centimeters. So then I'm taking my hand piece off, and then I am hand driving the rest of it. And all surgeons are different. I'm learning this as I'm hanging out more with a bunch of dental surgeons, is that some dentists like to use a hand torque all the way down with their implants, and some people like to start with the drill. I personally like to start with the drill. And then just making sure that I'm at my SP2 position. And so it's just going to be right below that black line. And then I want to make sure the dot is straight on the facial. And that's just going to help me line everything up at the end. This is what it looks like when the driver is in there. And then one of the things that I was kind of going back and forth is, how do I have confidence that it's really in there and placed well? So I know I torqued at 40 Newton centimeters, but what does that mean? With my surgeon, like they've done thousands and thousands of reps. And so they can feel the density of the bone, they can feel how stable it is. But when you're newer in the journey, you don't have that tactile feel right away. And so that's where I love this Austell. And so you put in this little, it's called a smart peg that you put in, and then you use the Austell to read how integrated the implant is. And so you do a buccal lingual and a mesial distal, and then I record that, and then I gauge that, whether I can put, if I need to cover it, if I just need to put a cover screw on and close it up, if I can put an abutment on it, or if it was in the anterior, if I could temporize or not. And so there's a whole range of numbers that I'm going to follow, and that's going to be my personal guide. And then when I am ready to restore, before I put the crown on, I check again and record that number. And that kind of takes that element. It's a safety element in my mind. It's just total peace of mind that I know that the implant is integrated. So the next thing I do is I take my CEREC scan post and I scan the patient. And this isn't because I'm going to restore right away, but I have the scan ready to go so that I can use that in my third appointment. So I seat my scan post, I make sure it's seated all the way. I make sure the notches are lined up with my scan post and scan body. Scan the patient. And then I can develop the tissue wherever I want to at this point, because it's going to heal up. But there's nothing better than this screen right here, because it means that my guide worked. Like I knew where my access point was going to come out of. It's right in that central fossa. To me, it's like a good kudos check. And sure enough, easy screw retained crown. This is a crown that's just going to sink right in. This is a patient who has had a Holly retainer forever and ever. She's an adult and she just was waiting to get implants. And so I know these teeth aren't going to move. So if I wanted to, I could have this ready to go in her 3-month or 4-month checkup, depending on how long we want her to heal up. I mill the crown. And then I am not seating the crown at that point. Like I am very much putting a healing abutment on there. I'm suturing up the patient. And here is the implant placed right where I wanted it on the guide. And then 2 implants in a single day. Like these are easy sites. They're a little narrow, so I definitely wanted a guide there. I always want a guide no matter what. But these are the cases that I like. Like there's a lot of abundant bone. They aren't scary. These are really profitable and efficient cases. And then she comes back and 4 months later, 3 months later, I think I let her sit for 4 months in this case. My crowns are ready to go and I deliver them. Screw retained crowns, they sink right in. This is a 20-minute appointment. So I kind of did my surgical journey a little backwards. So I was really comfortable with these abundant bone sites that were either missing teeth or already healed up. Someone else had taken the teeth out and grafted, because the surgical part, the extraction, was the part that scared me. But I knew if I was going to get into this more and more, I needed to push myself a little bit. And that's what we're going to talk about. So in this case, like a lot of people are going to look at this and be like, oh, this tooth is no problem to get out. But these are the teeth that scare me. Endo treated teeth that are just mushy. They come out in little pieces. And then if you have to get out a hand piece, like I just feel like I'm taking away all this bone. And, this is kind of a narrow site. And if I'm going to put an implant here, like I want to do the least amount of destruction. And that's where I was introduced to this surgical piezo called the Cube. And I am 100% in love with this. So this does so much more beyond extractions, but this took me from not wanting to ever touch an extraction site to now just getting so excited when I get to do an extraction. And it's almost like a small, thin periotome. You're just going in and you're going around the tooth. There's water the whole time. You don't want to keep it still. You're like doing this sawing motion all around the socket of the tooth. And it takes probably a little bit longer to go around the tooth all the way. You really make sure the tip ends up kind of dipping all the way down. It won't cut bone away from the side teeth. It does such minimal damage that by the time you've done going all the way around the tooth, literally the tooth just kind of pops out. It's amazing. So I use the Cube. I loosen up that tooth. I then just take a spade, which is my also newfound love of instruments. And then the forceps, I could probably honestly use cotton forceps, but I really make the patient feel good by using forceps to just wiggle that out barely. And we're ready to go. So in this case, I'm going to do an immediate implant. Now, if I didn't want to design my own guide, then this is another option. And there's a lot of third parties out there who can design different guides for you. In this case, I've really enjoyed the SprintRay Cloud designs. They're really fast, and they're actual doctors, they're dentists who are designing it for you. I also have full control. So in this case, I was doing an immediate and I wanted to use a little longer implant to grab a little bit more native bone. So I got the original plan and then I wrote back and I was like, hey, can we just switch it to this implant? And then I got it back right away saying, yes, here's the new implant plan. And you get this recipe that also, just like within the ACTEON Prime, it tells you the drill lengths and what stop position, and it's about $100. And then I'm going to print it in my office again. And literally in design services, once you approve the design, there's just a little green box that says print, and you just hit print. It sends it to your printer. It doesn't matter where I am. I can be at home on my laptop and hit print, and it will go to my printer in the queue, ready to go. And then, so here's one of their surgical guides. And so I've already taken out the tooth, and here we're going to do an immediate. I have my first drill with my keys, initial drill, just hubbing all the way down. My second drill, same thing. I'm undersizing my osteotomy a little bit. Implant is placed. Removing the drill after I get to the proper torque, and then I'm back at my ostel. And I really think the ostel is important in something like this with the immediate. I get a reading. I have a little bit of space. What I've learned in my journey so far is that if I'm doing an immediate and I have more than about 1.5 millimeters buccolingual, that's where I'm going to graft that site. I scan just like I always do. So I want to know, like, yep, I was in that perfect position. That's exactly where the guide said I was going to be. In this case, I used a true abutment, which I really like for the immediates because it's a variable height tie base, meaning that it's moving my platform up. In this case, 1.8 millimeters from 0.8 millimeters. If you're in the CEREC world and get all nerdy, and if you have questions about it, please ask. Again, this is just my woohoo. Yes, I'm in the right spot. My verification. Mill it, I can have it ready to go. I'm not using it the same day. I personally just like putting my healing abutment on there, but I will have it for the appointment. Here I'm just finishing up my graft, and here is my implant placement. So when I started doing immediates and the extraction, like, that was a big deal, and I attribute that all to the cube, all to the surgical piezo. But will I really use the surgical piezo? So, do you need it for extractions only? So again, I like everything pretty clean when it comes to extractions. I'm very systematic. I keep it simple. I keep it clean. I don't want to get overwhelmed by what instrument, by having 1 million instruments out there. I have a very, very simple program. And one of that is always going to be my cubes extraction tips, that's what's going to be on that lower left screen there. There's different angles, whether you're on the mesial, distal line angles, you can switch those tips. So here's a case that the patient, she needed a crown on number 5, and then she needed number 4, that root tip out. And again, you can see it's an endode and it is just pure mush. So I don't want to just dig this out and dig this out. So I got her numb. You can see that tissue blanching. I like to do a lot of local just right around there. And that just kind of also, that fluid helps kind of push everything out. And I use the piezo. So I prepped my crown first. And normally if I was doing extractions, I'd be a little bit nervous about this. I wouldn't want to necessarily prep first because I wouldn't want to hurt my margins at all. But I also didn't want to prep with an open socket. And so the other advantage that I love about the surgical piezo, the cube, is that it won't hurt my margins at all. So what's great about it won't do any damage to that tooth next door, even if I laid it on the margins. So I was super, super confident that my crown was going to still fit. So my crown's being made, it's being milled while I'm doing this extraction. I go all the way around the tooth. I use my spade just for my final wiggle and clean my socket out, and out the tooth comes. And now when I see an endode tooth, that's all mush. Like, I'm not scared of it anymore. I still do molars. I split the molars. One of my favorite quotes was when a surgeon who I just respect so much, he said, "Oh, I only take out single rooted teeth." And I was just so shocked that he said that until I realized he meant that he splits all of his teeth. He only takes out single roots because he splits them all. And now it's my technique and what I do, and it makes life so easy. But what about a harder tooth? So I do a smile design course down in Tempe, Arizona, where we have patients come in who need some new smiles. The last one we did was for domestic abuse survivors, and we do it with the CEREC, so we deliver same day. But sometimes things don't always go according to plan. And that's one reason why I absolutely love life patient education, because with typodonts, they always kind of go according to plan, or you can always fix it. But in real life, what if the decay is too much? What if a tooth is hopeless? Then how are we going to fix it? And in clinic, we have the capability to fix it however we need to, whether it's a bridge or endo or an extraction and implant. So in this case, we prepped the teeth, or the student who was taking the course prepped all the teeth. And then we discovered that number 6 was absolutely hopeless. We tried to, at first we thought maybe we could save it with endo, but the mush was just too much. So it needed to come out. And all my geeky surgeon friends were just so excited because it was a class 1 socket with this canine, meaning normally with a canine, you cannot do, or you maybe shouldn't, or not always do an immediate implant placement. But because there was so much good bone here and so much good gum tissue, it was a possibility. So the preps are done. Don't want to hurt the preps. And so this is what the cube looks like. You're literally just kind of brushing that tip all the way around the tooth. And again, when we do this, we're not worried about hurting the margins at all or doing any damage. Also, because we're going to do an immediate implant, we're not overexpanding the bone or damaging the bone around there. So it makes it a great immediate socket site. And lots of water spray the whole time. So you have suction, and that tip, if you watch and as you do it, is just going to go further down the socket and further down the socket. And that's how you know you're severing those periodontal ligaments and getting the tooth nice and wiggly for you. So once you go all the way around the tooth, then he's using the elevator. And you can see this tooth is just ready to come out. And this is my favorite part. This is one of the biggest canines I've ever seen. It was this huge, long canine, and it just came out so elegantly with the cube. That was the first time this doctor had ever used it too, which was fantastic. Implant was placed. Ostel, again, we want to make sure we have that really good primary stability. And we even got to temporize this. We made sure out of occlusion completely, and the rest of the case was restored. So pretty exciting. So is the peritome only for extractions? Not peritome, excuse me, piezo. No, it's not. You can use the piezo for so many things. What I see as the most popular is definitely lateral sinus lifts. That's where doctors have absolutely fallen in love with it, and it's added a lot of security in there. I'm not quite there, it turns out. When I can see the sinus membrane, I still get a little woozy. I tried really hard to expand my horizons, and I just did another surgical class, and in the middle of the class, I was seeing a patient, and the mentor came over and said, "Oh, let's make this flap a little bit bigger," because like I under reduce crowns, I under reduce my flap sometimes. And so he went in and he was showing me, so he tented it up, and all of a sudden, luckily I had told my buddy that I have this vasovagal problem. I ended up turning white, and I said, "Oh," and my mentor was like thinking I said, "Oh," because of the surgical technique and how fantastic he was. But I said, "Oh," because I was literally about to hit the floor. So my partner, who I was in class with, she stepped in. The patient had no idea that we even changed. I went against the wall and slid right down. So I'm not right at the sinus lift level yet, but I'm hoping to be soon. But I have definitely seen a lot of them, and I'm excited because my confidence just keeps growing with all the technologies and all the tools. So again, if anyone wants the checklist, happy to give it. Just shoot me an email, and I am an open book, happy to share anything that I can. This is definitely what's helped me and helped my team just keep it, again, a non-event, make it non-scary, always helping to confidence. And then I'm a huge fan of live patient education. So especially when it's in conjunction with giving back, and especially when you know that these patients are taken care of comprehensively. So I started my personal journey at 3D dentist in Raleigh. And then now I work a lot with implant pathway and the clinical pathway side. There's different programs out there. You get a Good Samaritan license and you get to do some good while also doing some pretty amazing education with a mentor literally at your side, to make sure these patients are safe and that you feel safe and comfortable and don't pass out in the middle of a procedure. And if there's any questions, I would love to answer them. Thank you for tuning in and watching the webinar. I sure appreciate it. And hopefully for anybody who's a little nervous on the surgery or implant side, this will help give them some confidence to start their own journey. So thank you very much.
Awesome. Thank you very much. We do have about 15 minutes. We got a couple questions here, but if anyone does have additional questions, feel free to use the chat or Q&A. The first one here looks like a clarification on the piezo. So it sounds like you're saying the piezo only cuts bone and it will not cut the tooth. I have not found that to be the case with my piezo, as it definitely cuts the tooth.
So with the tips for the extraction kits, I've never had it cut tooth. It will only cut in like the periodontal ligament area. There are some other tips where it will cut tooth, but not with the extraction tip kit. So hopefully that is some clarification.
Yes, thank you.
Mm-hmm.
How many teeth do you get to extract before replacing the ACTEON tips?
Geez, right now I feel like we're extracting so much. I haven't had to replace a tip yet in my clinic. And we take out, I want to say, I mean, we're typically taking out anywhere from like 2 to 4 teeth a day with all the teeth that are breaking. And that's between 3 doctors in my practice. So I have heard that they are breaking. I've had some people ask me questions about that before. I just haven't seen it personally. And we've been using it for a little less than a year. We're not taking out 3 to 4, I guess, every day for a year, but I talked to ACTEON a little bit about it, just making sure that the tips are really screwed in all the way so that there's not a lot of wiggle in there. And then making sure you want the piezo to do your work for you. You don't want to have to like keep pushing super hard where you're using it as a torque device. Like you don't want to use it as an elevator. So that could also be some of the problem. But if anyone wants to email me specifically, I'm happy to connect you with ACTEON. There's some amazing support in there and we can see what's going on.
Why not either peritomes or periotomes?
So you can absolutely use periotomes. It's kind of like burrs, like what's your favorite burr versus what's your favorite extraction. I use a set called elevatomes, and that spade's just part of it. I don't know what it is about the spade, but I feel like I can get out any tooth with the spade. But one of my doctors that I work with, she takes out a lot of teeth, and like she has one that she calls a dog leg that she can't work without that. And my other doctor that I work with has her own favorite periotome that she uses. So I think a lot of that is just what feels good to you. I would say my spade is maybe my lucky instrument and I don't pass out with it. So maybe that's why I keep it, but I think that's a personal preference. And if you talk to 10 different surgeons, they would tell you 10 different things, just like your favorite burr.
Anything to get the job done, right?
Yeah, exactly. Yeah. What feels good in your hand?
Exactly. What 3D printer do you use for your workflow?
I use the Sprint Ray Pro 95. I had a different printer before, and because I had to use a third party in there, it always ended up that I was the one that had to do it all. And what I found about the Sprint Ray, ended up switching it out. The Sprint Ray is just literally a click and print. And so I just sucked it up. My other printer is just collecting dust, and my Sprint Ray gets used every day. So we joke that we're a no goop office, and like all of our models, we just scan and print for our Essex, for our suck downs. We do our occlusal guards that way, surgical guides. We do as much as we can with the printer and absolutely love it. And the Sprint Ray has just been a workhorse.
We have a couple cost questions. Don't know if you're equipped to answer them, but I know we have some ACTEON folks on here as well. So feel free to let me know. First question is, how much does the piezo cost?
I am going to have one of the ACTEON reps do that. I know there's always like part of the surgical courses, they always have the specials and stuff. So I'm not sure what the actual price is. So if someone could hop on with ACTEON, that would be awesome on that one.
Yep. Looks like approximately 6,500. Can be less with Q4 specials. There's your plug.
Perfect.
What is the cost of obtaining the box?
The cube.
Oh, that must be the same thing. Okay.
Yeah.
Ignore that. Can you use only external irrigation with the guide, or do you need drills with internal irrigation?
All of my drills have internal irrigation on it, but you could use external irrigation with the guides as well, because the access with the windows and then through your channel, you can absolutely get irrigation through it. Or if you're worried about irrigation, you could always pop your guide off in between drills as well and irrigate and then put your guide back on.
All right. I think we got through all the questions. Let me double check here. Yeah, I think here. What is the cost of the ACTEON Prime?
I'm going to let one of the ACTEON people, it's like a third of the cost of my original CBCT, which is amazing. They've come so far.
Yeah, they're saying 60,000.
Yeah. Yeah. So literally a third. And it is, it's great technology. I'm very impressed with it.
Cool. Well, I think we answered everything. So with that, we'll end a tad early tonight. So thank you, Dr. Aadland, for the amazing presentation. And of course, thank you to ACTEON for sponsoring tonight's webinar. If anyone does have additional questions, please feel free to reach out to Dr. Aadland directly, or you can email us at webinars@henryschein.com, and we will be happy to route your question accordingly. If you'd like to attend future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. And lastly, we did record the webinar tonight, so that will be sent out to everyone within 1 week of today. Thank you all for joining. Thanks again, Dr. Aadland, and have a great night, everyone.
Thank you so much. Appreciate it.